Assalamu alaikum again. Thank you, the attendees and the students for your continued engagement. I am really impressed by the Rawalpindi Medical University students who have really, no, I honestly think when we were sitting there as students, we were not as sharp as you guys are, because we react. Because I've seen since yesterday, you react at the appropriate time in an appropriate manner, and that shows your engagement. And you should clap for yourself. So, with that, I think we are halfway since yesterday. We had 6 working sessions. We are done with most of them. We are left with 2. And so this session is really important because, as some of the panelists before in the previous session pointed out, that it's very difficult. This is called economics of any discipline or project. Where will the money come from? So that's obviously, as doctors, we are not trained, as medical students, we are not trained to think about it. But the reality is somebody is paying for services, whether it's an insurance companies in the Western world which pay for services for the doctors, or NHS like in UK, National Health Services, the government paying for the services of the doctors and nurses and medicines. Or in Pakistan also, the government tried to obviously pay for the free patient care. But as you know, it's very difficult for any developing country to pay all the services for free. So should we think about a model which is different than just for fee for service or just the government paying for it? So this next session basically addresses that. Is there a way that we can think outside the box? Is there a way that private and public come together and have a partnership? Meaning that the businessmen or business world coming together with the government and setting up a system where doctors are paid according to their, their abilities and their hard work, and the patients are taken care of in a better way, in a good way, and all the medicines that are required and all the preventive care that is required is available to them. So this is the topic for this session, and I would like to introduce our chair, Dr. Nahid Usmani. By now, everybody knows Nahid, that she is the president of APPNA 2020, and but basically she's also an academician, a very renowned academician who is a professor of pediatric oncology. So it's a very specialized field. So first pediatrics, and then in the pediatrics, the subspecialty is oncology. And so she already served in Pakistan from 1994 to 1999 in Shaukat Khanum Memorial Hospital when it was started. So she was one of the pioneer or founding people who developed this fine institution in Pakistan, in Lahore, and she played her role, and she went back. And still she continued to work with Shaukat Khanum and advise them and consult them, and whenever she comes, she visits them and give back to that institution. But that is just that institution. But as an APPNA activist and APPNA leader for a long time, and now president, she has served, and that's her mission, to give back to the country, to the Pakistan. And so this merit committee that I'm standing as a chair today was founded by her in 2007. She started this committee, and and then she remained chair of this committee for 5 years, and she made a solid foundation on which it has been working to this day to the great advantage of Pakistani healthcare system and medical education, and has done a lot of great work since her time, continuously all this time. And this conference is actually the turning milestone. It's a great flag in the cap of, or feather in the cap of this merit committee, APPNA merit committee. So we are all happy that she's here. She's the president of APPNA now, and so she'll be chairing this session. Now let me invite the panelists one by one, and I will request them to come to the stage. Professor Zafar Zaidi, FRCS, Fellow of European Board of Urology. He's a pediatric urology professor in Indus Hospital, where he co-founded this great institution. As all of you know, that Indus Hospital system is one of the finest, and not only the finest, but it's free. And it's one of the first or only institution which is paper-free. When we were talking about technology and the electronic health record, Indus Hospital already have that. And so that's great that an institution like that exists in Pakistan. And not only it started in Karachi, but now it has multiple hospitals. And 13 of those hospitals were established by him as a director of medical services. And then he was appointed dean in 2018, and during his time he also founded and established the family medicine department, and one of the good solid department in the country is in this hospital system. So we are very grateful and lucky to have him here today as the panelist of this important session. Then I would like to invite Professor Muhammad Professor Muhammad Amir. He is the Dean of FHD Shifa Tamir-e-Millat University and Principal of Shifa Medical College. Professor Muhammad Amir is a graduate of King Edward Medical College, and he did his fellowship in surgery from CPSP and RCSED. He's a professor of surgery, and also he was instrumental in the development and successful implementation of integrated system-based curriculum at Shifa for more than 15 years. And as you know, the Shifa has one of the finest curricular system, medical college. A lot of their graduates are outside in United States as well. Under his deanship, the Department of Family Medicine was established. And as you know, that the Department of Family Medicine is in very few institutions in Pakistan. And so Shifa is one of them who has a full professor of family medicine. And he was instrumental in expansion of services to the community in rural as well as in urban areas. And his aim is to start the postgraduate programs in the family medicine, which I think already have started. So thank you for coming, Dr. Muhammad Amir. Now next panelist is Dr. Syed Shah Miran. He is the chief executive of MERV. He is a public health professional and medical director with postgraduate qualification in healthcare management from University of Manchester. Over the past 15 years, he has been serving as humanitarian and developmental professional with interdisciplinary and sector-wide technical and managerial experience, both nationally and at an international level. Currently, he is serving as CEO with MERF, which stands for Medical Emergency Resilience Foundation, and he is implementing various public-private partnership projects in Sindh and KPK. So he's the right place at the right time. This session is about the public-private partnership. So with these illustrious panel, and of course the chair, and we are still waiting. I called NUMS University Vice Chancellor Office, and I was told that Dr. Majid, Lieutenant General Imran Majid, has left his office, probably stuck in the traffic at this time, but we can continue to start and discussing, and once he is here, I think he's already here, I can see, so we can invite him right away. So I know Lieutenant General Imran Majid for few past years as chair of APPNA Merit. He has been very instrumental and very interested in partnering with APPNA. Assalamualaikum, Imran. So he really very forward, very progressive-looking leader in the healthcare in Pakistan. And NUMS, as you know, National University of Medical Sciences, was started recently in 2015-2016, and as a founder of this fine institution, Dr. Imran Majid has helped its foundation, laid the solid foundation stone, and always looking forward to new ideas and new expansion of his leadership. And one of that would be today when he will discuss and let us know about his vision and what he is involved in as a public-private partnership. But before he was the Lieutenant General and founder of NUMS University, he has served as Surgeon General of Army Medical Corps, as well as the Commandant of the Armed Forces Institute of Cardiology. And by profession, he is a cardiologist and has had a very illustrious career, and along the way earning the second highest award in the military, which is Halal-e-Imtiaz military. So I think we should start this session by inviting Lieutenant General Dr. Imran Majid to speak about this topic of public-private partnership.
Thank you, Shahid. Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, Assalamu alaikum. My apologies for running late. This is the progress and why public-private partnership is required, because if you leave everything to public, then this, what used to be traditionally a 15 minutes journey from MH to this place, got converted into 45 minutes. So let me get on with this quickly. There are going to be a few aspects of what I'm going to highlight here. Firstly, the need for family medicine, why it is going to be difficult for the government alone to be doing it, and what are the challenges that if the private sector would like to get into this, would find it difficult to do alone, particularly when we look at things from the Pakistan's cultural and socio-economic aspect. This is the kind of model that I believe is likely to work. To begin with, let me please highlight to us all that when we are talking about healthcare in Pakistan, what is actually the challenge that we are facing? I frequently allude to this particular study, which I believe is probably the biggest, most important study. It was a very well designed study carried out by the World Bank or on behalf of World Bank, funded by the World Bank, conducted over a 3.5 years period from 2004 to 2007, wherein 350,000, 3.5 lakh families of Pakistan were studied to find out what are the serious crises or shocks that people of Pakistan have to face. Now, all the socio-economic classes of the society were studied. The definition of serious crises or shock was that either something happens in which either a family member would die, now that's serious, or while trying to save that life, the family will have to dispose of their property to that magnitude ke gaadi, zameen aur sab kuch bech denge, that the impact, economic impact would be so much that the family would be degraded by at least one economic class, the middle class, high, lower class mein convert ho. So that was considered serious. The important thing for us health workers and policy makers is to realize what is the magnitude of healthcare related shocks. Now, typically we think that when something goes wrong in Pakistan, it has to be law and order. Peculiarly, only 3% of serious crises or shocks were attributable to deficiencies of law and order. Economic shocks, 28%. And double that number, about 54%, were on account of paucity of healthcare. So attributable to paucity of healthcare, 54% shocks. Now that's the type of challenge that we are faced with. Now if we leave it all to the government, let's be very honest and frank for a while. How can government or all the governments that have come in, I would like to defend the governments, वो भी हम में से होते हैं, they try their level best to provide solutions, but are not able to find that fiscal space so as to be able to budget healthcare adequately. If we are something like 50-60 million sizable, very well affording middle class, and only 2% of this middle class is tax paying, what do we expect from the government? So that fiscal space to budget healthcare is not going to come. Of course, we realize as healthcare workers that the way the healthcare system or the public aspect thereof evolved in Pakistan, it is largely tertiary care based. I'm not challenging the relevance of tertiary care. That mandatory requirement is still there. But that primary care, which should be the bulk of it, so what we are dealing with is a kind of inverted pyramid. We have a large tertiary care and almost non-existent primary care, particularly in urban areas. You know, the government would obviously, for the absolutely downtrodden or not able to afford. So we had developed somewhere in 50s, come up with this basic rural health centers and basic health units, which will provide something in areas which would have otherwise absolutely nothing. Now, in more quality conscious and affording urban area, that responsibility wasn't ever taken up by the government, and we were never able to develop a public healthcare system. For example, if you look at the National Health Service of United Kingdom, it's hugely primary care, and then there is a pyramid proportional tertiary care. I mentioned this one aspect that quality consciousness of public sector, of primary care, healthcare in urban areas. Because, you know, people living in urban areas, they exchange notes with all their colleagues, friends living anywhere in the world. They have more awareness, more access to knowledge, and they expect and want, they demand more relatively better quality healthcare. Why it is not possible for the government, if we look at the public funding of healthcare as a percentage of GDP when we are preparing budgets, Now, the entire annual recurring and developmental, federal plus all provinces combined, the total budget as a percentage of GDP in history of the country, we never budgeted even 1%. We made a record this time that it is 0.96%. We all understand, particularly those who have been on senior administrative positions in public sector, that about 30–40% of this money is never going to be utilized. So in effect, probably it's 0.53% of GDP is actually whatever got spent in any one year in the history of the country. And you know what is the average for nation states around the world? 7.3%. I'm not talking about the developed world where it is not less than, it's always 9.5% plus. Not talking about the United States, where the public budgeting, I think for 2 years ago was 17.16%. So if you look at the population of the United States is merely 40% more than population of Pakistan. So the year that we budgeted, which was maximum ever, was $2.5 billion equivalent. I said all the public annual development and recurring budgets, federal and provincial. At that time, this was a couple of years ago, in US it was $1.67 trillion. So it is not going to be possible for, again, I'm sorry, saying for a largely non-tax paying population to be asking government to do the job for them. There is another problem. If we try to do things entirely on private sector basis, we are viewed with suspicion, many a times rightly so, because we say it's difficult to regulate and it is too much for profit, and that's an issue. And when we give it all to public, I said one is it's difficult to fund it, and then there are big question marks about the ability to run it to that quality. So that's where the best of the two worlds, we have to develop some sort of model. One would like to give one's own views on this, and I believe that whenever we talk of this triple helix model, I think the problem is that it also has to be socially, culturally, and economically contextualized to one's own situation. For example, one is of the view that we have experimented with we have in public sector, the healthcare, we are managing to the extent that is available. And private sector is contributing significantly, obviously not on that scale, but those pockets of excellence, be that Aga Khan University starting their family medicine, Shifa Hospital venturing into it. I know Shaukat Khanam always tries to outreach. But what is the quantitative huge impact for, remember we are 215 million and going strong population. I believe it is time to where Professor Umar Saab बैठे उनसे भी बात होती रहती for universities to come in and take this initiative कि ये जो चीज़ है, क्योंकि public universities should get into partnership with the private sector because they have an ability, I believe, I hope, that they are likely to be listened more. They would be taken a little more seriously than the way our public health departments are run, which have some representation of medical technocrats and otherwise civil servants. Probably whatever that model is doing its job, I would argue fairly decently given that budget. But maybe the universities can, and there are models of university-run healthcare systems. If you look at that is the dominant model in Iran, and they've done a fairly decent job. Even in the United States, even at the upper end, if you look at, for example, in New York, now the New York Presbyterian system is very intimately linked with the Columbia University and Weill Cornell. Although if you look at their budget, Their budget is 3 times our national health budget. But you know, again, if you find private and it's run mostly on donations and so forth. But if we are able to bring in that private entrepreneurship, I'm sure we are going to be able to, and have this morally, ethically strong and academically and robust oversight mechanism. I can't give you a ready solution for this, but I believe we inclusive, some of the universities now in Pakistan are talking about this. I think I should stop here. I had already consumed my time on road and I may have short my time. Let me check out this. Thank you so much.
Thank you, General Imran Majid. So I would invite our chair, Dr. Nahid Usmani, to give her comments in view of Dr. Imran Majid's view and overall general.
Assalamu alaikum, everyone. I've been rather quiet today, haven't I, compared to yesterday? So, private-public partnership. I just want you to remember some of the statistics I reviewed yesterday morning, that 70% of Pakistan's health budget is spent on tertiary care. Less than 30% is spent on preventative or primary care. And secondly, most of the primary care expenditure in this country, 67% or close to 70% happens in the private sector. So very little of the primary care is happening in the public sector or the governmental institutions. So how do we change the paradigm? Our education for medical schools, the premier medical schools, are primarily public medical universities. How do we create that partnership where they can have a connection with primary care private practitioners in the community? And this is a model that has been adopted in many American teaching institutions. I will go back to my University of Massachusetts, where all the private physicians, primary care physicians, whether it's the university has its own family medicine program, but they also have private practices of primary care that are linked to the medical school, and students rotate through there. And the residents rotate through there in a system of longitudinal clinics, long-term preceptor clinics, so that students from very early in their medical education are exposed to the principles of primary care. Everything that has been discussed today, presented by Dr. Rafiq, by Dr. Temina, what primary care is in an American system, is learned during medical school. So that's one point. Second point that I really want you to think about is, it's no use comparing what America is spending on healthcare. It's very disproportionate, there's a lot of wastage. Pakistan should not follow that model, absolutely not. But Sri Lanka is a country which is in South Asia, that is a developing economy, but has more or less similar economic indices as Pakistan. How come they have such amazing statistics, healthcare statistics, that they have no smoking, that their life expectancy is close to European standards, that their infant mortality, their maternal mortality, all those statistics are so much better than Pakistan. The only difference is that it is investing its health expenditures on primary care. So what should be the way forward for Pakistan? I think the way forward for Pakistan would be a very healthy, robust public-private partnership, whether they are private universities partnering with public universities or medical schools, or whether there are public medical schools and universities that are reaching out to primary care facilities so that the students can learn principles of primary care and establish primary care education. If we started a system or standardization of what is required of general practices within our cities and towns and hospitals, and we impose those standards on those private practices, the whole status, the whole level of primary care that we give to the Pakistani population will improve. I think that is the way we have to go. We have wonderful speakers. I'm very eager to learn about the other models. Electronic health records at Indus, I saw that about 15 years ago, and recently as well. Yes, when I was trying to discuss telemedicine at Indus, yes. Well, thank you very much for giving me this opportunity.
So while we are waiting for the audience to put their question on the index cards and give to the students who will be collecting those questions, I have few questions that we gathered from the pre-conference teleconference with talking with the various primary care physician leadership. So the first question that I have for panel is that what incentive is there for family practitioner in the private sector? As you know, the physicians who are with the procedures such as cardiologists doing cath and other echoes and same way with the surgeons, and there is a bigger reimbursement. So what do you think is the incentive model, or why should the students who are thinking about family medicine should go in family medicine in the private sector? Do we have the mic?
Thank you. First of all, I'd like to thank APPNA, Rawalpindi Medical University and HEC for organizing this, and for all the audience who've been here patiently listening to all of this. Before I actually answer your question why, I think the desire to have universal health coverage, which we now very frequently hear, will only be possible, and the stumbling block for it is not going to be money. It's going to be the human resource. In this country, whatever you try to do, you find the money. The people here give money. There's a lot of philanthropy in this country. What stops us is human resource. We cannot do it. Just a prime example, 1.5 million nurses are needed in this country. We produce only 35,000 a year. It'll take so many years to just come up with these numbers. So what is the incentive for a private family physician? I think for them, a better working, where they can produce better results for the patients. So it's a comprehensive care. For them, obviously, it has to be economic bound. They have to be remunerated for the work that they do. There's no way that anybody, me, you, or anybody else would work free of cost. Importantly, what they find is that they don't have access to good investigations. They don't have access to their patients when they are unwell to go to the hospitals. And the reason is that we are treating primary care physicians as standalone physicians. And that is, there are many groups, but majority of our general practitioners in this country do it in their own clinics as a standalone thing. It is important that we start looking at, as Dr. Naeed Usmani has certainly pointed out, where the universities can play a role, where we look at trying to produce models where we have groups of physicians, of family physicians, fairly well trained, which are linked to the hospital. That's where they're going to feel, and that's what will be the incentive for them, is that they have an active support from the hospital, be it secondary care, be it tertiary care, or whatever level. Many of there are people sitting here who've got groups as general practice groups now, but what they are doing is they're investing in investigations themselves. They cannot at all promise quality control because that costs more money. But if they were to link with a bigger group, with hospitals, that will be a government hospital, public sector or private sector, this part of their job can be taken care of. The only way we will be able to achieve this is that we trust each other. But currently there is a triangle of mistrust. The government doesn't trust the physician doesn't trust the government, the people, the patient doesn't trust either of them. And that needs to change. The government should be a better regulator and provider of ways for them to work better. The private sector should provide with funds as well as with opportunities for them to grow. And the patients should be educated, and they will only get that education when they have that confidence that when they go to a doctor, they are taken care of holistically and in a better way. Because I think a lot of our public sector hospitals are now inundated with patients who should not be coming to them. We created in our hospital what we started, a filter clinic. The idea was to filter out walking patients who needs to go where. But with our family physicians who came around, and some of them are sitting here, I'm very grateful to them, that they've taken on that role to actually be the gatekeeper of the hospital. So patients walk in there, they are seen by family physicians, who are our employees, full-time employees. Those who need to be seen by consultants are seen by consultants. Those who can be dealt with there, even with chronic diseases, are dealt over there. And those who don't need to come at all are also dealt over there. Investigations are done, whatever needs to be done. So as a result, as a specialist, I only see things which are appropriate to me. Only those things which are appropriate to the hospital come inside the hospital. The rest are taken care of by the... You can take this model and take it 10 miles away or spread it to 50 miles across, and that will be the way that you will be able to deal with a lot of the patients. I mean, I've seen a patient who has now hypertension, is well controlled, can be very well managed by them, as any other vertical program. So family physicians, and what your question is, what will be their incentive? Their incentive would be that there's a continuity of care. Their incentive would be that they get the respect which currently we don't give it to them. Every student sitting here, and I know for a fact when they join in here, their iconic thing is to be a cardiologist, cardiac surgeon, nurse. They have not been exposed to primary care. I, as a doctor who's very much involved, saw a basic health unit for the first time in my life at the age of 50. How appalling. You know, until and unless these guys, as you correctly mentioned, they have been exposed to it, the training is part of it, and in the incentive that you're talking about, if the universities, as General Sahab has mentioned, if they start adopting these primary care centers, then also give them an academic post, also give them a title. In this country, for whatever, and I'm one of them, being an assistant professor, associate professor, professor is a big thing, although it is not, to be honest, but it is still considered as a major thing. So if these type of associations are built with the private sector, their general practices, and the university, the hospital can control the type of work that they're doing, supplement them by educating them, there will be a good build-up. With 40% of health being provided by private sector in this country, they have to be partnered with, and there has to be ways where the government cannot do everything at all on its own. We will continue to dream of it, and it's not going to happen. The private sector, they are looking for money and how to get investment and to get interest out of it, whatever they can. And there has to be a common ground where everybody has to work for the country. And I feel that's the way, that there has to be a respect for the general physicians by the institutions and by the government, and then we can work together.
Thank you.
So I just need to make one, while totally supporting all that you said. You started with कि ये जो healthcare की workforce का. Let me please surprise you with some statistics. How many people, if FSC pre-medical first division was used to be a criteria that one could apply for a medical school entrance, और उसमें से जो कुछ रह जाते हैं वो nursing के लिए करते हैं. So let me give you figures. The whole, what is the magnitude of healthcare infrastructure existing in the country as a fraction of what is required? A good index is number of hospital beds per unit population. So World Health Organization proposes that any nation state should have 300 beds per 100,000 population. What we have in Pakistan is 62. So we are reeling at about 20%. And actually the gap is opening up because this is how we are building up the capacity. We need something like 650,000 hospital beds. And by beds, I mean jobs in formal sector. Now this is how we have been building up capacity and we are yet to reach 135,000 beds. We need 650,000 beds. Because the way we are in business of mass production of humanity, the curve, the demand is going up like this. So the situation is, infrastructure, 20% exists. Essential health care workforce, actually 39% exists. So there are people who are well trained, but they'll find it more difficult to get a job in Pakistan. They would be able to go into another more competitive market and by their excellence get a job there. So no wonder the third largest number of doctors in United Kingdom are from Pakistan. And in United States, the fourth largest number of doctors are from Pakistan. So we need to create jobs here, infrastructure. And again, the point is in primary care, as we all have been discussing, it doesn't cost as much as tertiary care. So it shouldn't be that difficult to create those jobs. Also the demands, it is still very charismatic to become a healthcare worker. You may not be able to become a doctor, but now we have nurses also going on to bachelor's degree. And a lot of universities have started bachelor's program for allied health professionals. Whereas yes, there is a bigger gap globally, demands for nurses and allied health professionals, whereas just about 2.5 million doctors are deficient in the world. For allied health professionals, it's 6 million negative jobs, jobs waiting to be filled, and 9 million nurses. Also, for medical schools, what we have is there are about 15,500 seats for medical students in medical colleges, total public, private in the country. So it's actually not 35, it's just about 12,000 for nurses, another 20,000 for allied health professionals. But people who envisage a career in medical, who actually obtain FSC pre-medical first division or equivalent OA level, you know what the number is? It is over 80,000. So the appetite is there, the need is there. We need to put money in and it doesn't require much money to build up primary care. Thank you.
Thank you very much. I will be short. I would like to answer this question in the context of public-private partnership with example. Currently, we are running a secondary care hospital in one of the very remote tribal district in KP, which is Aurangzeb district, just recently merged with KP. And when we started in 2017, there were hardly any specialists in that whole district. So we started services in that hospital under the PPP model, public-private partnership model. We offer good packages to the specialists. Currently now we have 8 specialties running in that hospital. We have a specialized human resource that are now available. We offer them good living environment. We offer them good working environment, having latest technologies, paperless system like the Indus or the other private sectors are doing. That's in the public hospital. Good lab and diagnostic services. And we are not facing any retention or any such issues. Now this model has been rolled out into 6 new hospitals in that newly merged district. And you will be surprised that now we have advertised the position, we are receiving much more applications for that very remote area. So the reason is, as was mentioned yesterday, good reward, good respect, good working environment. And interestingly, this is within the allocated budget. We are not asking any additional budget from the government. These are the allocated budget of the hospital. There's no provincial allocation, there's no federal allocation, and there's no external allocation. So that's manageable under the PPP. If we create such model in the primary health care under this PPP model, I think that will attract the new professional, new students, the new FP physicians to come to the primary health care to work in those remote areas.
Thank you, sir. I think your first question has taken a lot of time. If you have other question, we can respond to that. But I will just take a minute. What I was about to respond has already been responded by my worthy colleague. But I'll stress it again. It is a recognition. You know, like me, myself, and you people sitting over there, as Doctor mentioned, nobody would talk about, would think about primary care physician as a specialty, as a career of choice, because the respect, the recognition doesn't seem to be there in existence. So that's where the academia, the academic atmosphere has to be, I think there has to be a paradigm shift. And that's where the few institutions have already started, and I'll request that all of us should gear to that. In my opinion, the whole medical curriculum should be towards family practice or primary care, because that is where we all, as medical students in 5 years, should learn to become. And then there is a whole lot of work and academia available to postgraduate to do other specialties. So an introduction to those specialties is okay, but as a career, as a graduate, that is the first duty of any medical student, which in my opinion should be. But then that requires a recognition. So as this is the first, or maybe one of the few steps we have already taken, we have dedicated 2 days to deliberate on this model, on this, you can say, a theme, that how we can develop primary care and family care practices in our country to the grassroots level and to a level where we can say that our doctors who are working there, they got respect, they got recognition, and they know that they are imparting to the society which is not in existence at the moment. And they are also being recognized. So that's my take on this idea.
Thank you very much. So you're, sorry, just briefly, so that we have got a lot of questions.
Yes,
Yeah.
I just want to add another aspect of things. We have 2 problems, and they both can be solved together. One is the shortage of family physicians. And the other is, as you can look around, the feminization of our healthcare. And I'm not saying this in any negative way. There is a very large number of our female doctors who are not practicing. And nobody, myself included, has ever gone to ask them what their problem is. They've all been prescriptive. Ye wajah hogi, ye wajah hogi, ye wajah hogi. The fact is that primary care is a great opportunity for them to be trained, because they don't have to do night calls. And once they are trained, and remember this, once you are trained and have a degree, you have the most flexible job available in the world. You can work Monday morning, Wednesday evening, Thursday off, Friday night, whatever you want, because it's not like a hospital. For hospitalists that we train, and we continue to do an opposite prism where we are talking about cutting edge, robotics and this and that, it's a different world. You have to be on call and you have to do a lot of things. So this is where we can really try to tie this in, where we encourage all of our female doctors and provide them with the opportunity to become family physicians. They will be the best family physicians. They will be wonderful because they will have the empathy that we men don't have. And I'm a great supporter of them to be doing a lot of that and the preventive care that they can provide. And we can certainly turn this problem around.
That's absolutely right. But although I have a lot of questions in my hand, but it's one question in this regards when I think about different reasons why the female or lady doctors do not go to basic health unit or primary rural areas is the safety issue. Any take on that, how that can be provided? Or
I honestly don't think there's an issue. I don't think they find it, a lot of them are bright kids. When they come out, they don't want to have this type of a career. They want to have some postgraduate training of some sort, but they cannot because of the natural life cycle they're going to have to be involved in a hospital-based training. You provide them with a year or 2 years of a family and let them have a flexible, you would be surprised how much of these posts will be taken up by them. But if you're going to create a basic health unit for the sake of creating a basic health, I mean, how many of them I've been to where there's nothing? There's
No, I think I was referring
there?
to the security situation.
The security
situation.
there are people now coming to medical colleges from all over the country. And this is a great opportunity for people to stay. Nobody wants to leave their local area if they have that opportunity to work and gain a livelihood which is well enough for them to survive. So we need to start coming out of these myths.
Thank you.
This is a true myth.
Thank you. So we move on to the very interesting questions. This turned out to be one of the, really great session. And so we'll go through, we don't have enough time before the lunch, but we'll try to get to all the questions that I have in my hand. So the next one is that how do we control the quality and cost and monitoring? How do you monitor the primary care unit? Say, for example, the primary physician, you have the family physicians, and so there are one or two similar questions, so I'm trying to fuse them together. So basically what they're saying is that there are a lot of medical errors, not a lot, but many medical errors, and so how do you ensure that even after training, that the family physician specialist in wherever they're working are doing a good job? Who will collect those data and who will implement the quality control?
Again, I will answer this question in the context of PPP, public-private partnership, what is happening now. Because PPP is not new in Pakistan. A lot is happening around. For quality and costing in PPP, SIN has done a lot of work. They just recently established a model which they now want to roll out in the new PPP's initiative. They established essential delivery package with quality standards. So that's for primary care, secondary care, and I think now they are working for the tertiary care too. With these quality standards, they have developed the key performance indicators. And these key performance indicators have been discussed, have been like various stakeholders, including the private partners. They have involved on those selecting those KPIs. Now they have established a monitoring mechanism for monitoring these KPIs periodically. Now these KPIs for these PPP initiatives will be monitored by a third party. They call it a third party auditor. And there will be a tripartite agreement which includes the government or the health department, the private partner, and that third party auditor. Now, based on that third party audit, which will be either on quarterly basis or biannually basis, they will generate a report. And that report, that's mainly on the quality of services. Based on that report, the funding will be dispersed. So it's linked with the funding. If you have achieved your KPIs 80% or 90%, you will get 100% funding. If you achieve your KPIs less, you will get less funding. So it's like a punishment. And if you achieve well, you may ask for additional funding. If you have a high caseload or you have done more procedures, more advanced procedures. So that's
who are these third parties that monitor?
Again, that's mostly the independent monitors. So in SIN, they have put it that it should be a big audit firm. Big Four, they call it Big Four audit firm, and it's an international firm.
So we've been doing that for over a year. The problem with private-public partnership is that the public aspect changes with the aspirations of the political will. And that's a problem for the private sector. And for instance, we run the Badin Civil Hospital for Sindh government. And the budgets that were approved, there was a great difficulty in trying to get those funds across because there were delays, and that is the huge problem because the machinery is so big the inertia is as big. So what they did was, and we've been doing it and now it's been implemented, it's called an escrow account where the whole fund is put into an account which is now being transferred. There's an auditor and there are set KPIs done and the set monitoring tools agreed to. You keep meeting them, he signs off, keeps releasing the funds. So the whole machinery of the health department is now taken out of the equation and it is much easier to run the systems over there. So that's exactly what they're trying to implement in other setups as well.
Ji, Imran.
I need to bring in another dimension here. You know, let's not look at healthcare only from the lens of the doctors, because I think I'm feeling honestly very uncomfortable that it's all doctors who are sitting here, and right in front of me I see Rifat Jan sitting over here. It's very important that when we talk of healthcare, we include the society. So as you say, who will monitor, control? There should be other elements of the digital people and the monitoring. And also so many other entities have to come in just to highlight the role of the nurses. You know, Rafat Jan has been a strong champion for advanced practice nurses. When we come to particularly primary healthcare, I think a lot of functionalities have to be performed by nurses, and we must realize, a very strong force multipliers for us doctors. Thank you.
So thank you for that, because you answered one of the questions that said that the primary care is a collaborative effort. So why are we talking only about the physicians and the family physician specialist and primary care specialist? And it's rightly answered by our Dr. Imran Majid that it is not. It is really a collaborative effort, and nurses are very much part of the team that will deliver this primary care. So with that, we move on to another. So somebody said, can it be and maybe you can answer in the MRF, that probably that's what's going on as a pilot, that a unit or basic health unit, the whole of it, or a cluster of basic health unit can be given to a private entrepreneur who will manage them with all its complexity and be answerable and accountable to a third party.
I think, yes, that's the model which is currently being practiced globally as well as in Pakistan. We have the PHI model, we have the MDTF model in the past, we had the Butagram model in the past. Currently, as I said, Sindh is doing it. KP is planning to do it. They have started it in the newly merged district. And this is possible. And what we learned in the past 7-8 years, as General Saab mentioned, there's a very little allocation for health. But that allocation, even that allocation has not been properly utilized. You just mentioned that 30-40% budget lapse, yes. But even the remaining 60%, mostly if you analyze, it has been spent in the last quarter of the fiscal year, because there's various releases issues and all those things. So with the PPP model, these type of issues bringing the additional resources that can be sorted out at the primary healthcare level. And we have some very good studies. The TRF Plus, they did a very good study in 2018-19 where they compared the PPHI model, which is the primary healthcare model, the Butagram model, the MDTF model, and the government health facilities. And they show the remarkable success that has been achieved by this PPP model with the limited resources as compared to the government-run health facilities. So there are very important lessons learned in those models that need to understand, that need to consider before going to rolling out these PPPs in the family physician practices. Like the clubbing, if you do not have the resources, the Butagram model, they say they club the 3-4 RHCs, make it a hub, and where the family physician practice they establish, and that family physician used to spend two days in each of the health facilities. So in order to get more resources, they club those in a cluster form and provide that services. So we have this good lesson learned that can be rolled out.
I think the importance here is that you are becoming more cost effective by putting things together. If you had the whole infrastructure for one BHU, it will cost you X, and 3 times because you have 3. But if you have 3 together, it will cost you less than 3 times X.
Sure.
Because you don't have to, duplicate a lot of things. And the management will be much more local and easier to do than to do it from one primary and secondary secretary sitting in Lahore, for Punjab, with thousands and thousands of BHUs. So that concept has changed and that has to be brought in. Quality has to be assured, and that will only come from monitoring it and training people constantly to improve their quality.
So I think this next question is more of a comment, and it says that family medicine is a specialty, and to preserve its not only dignity but also the I think financial aspect, and here we call it in the West collateral referral. So what they are saying is that the specialist, it's addressed to the specialist, that they should not refer the patient to another specialist. It should go back to the primary care physician, and then they should refer it to. So we should not do a collateral referral. And I think it's a comment if anybody wants to add to that.
I think it's a valid point, and family medicine is a specialty, yes we know, but it is also taking care of the primary care needs of the society. So I think I have no problem with that, and we should agree with that.
Right. So next question is for General Imran Majid. It says, what government can do for bridging system of primary care in which tertiary care hospitals and secondary care hospitals only cater for those patients who are sick and only take care of the patients who are referred. So can we implement or enforce that no patient should directly go to secondary or tertiary care centers?
I think it's just opposite of what was trying to convey. Let's not talk about what the government can do. We need to talk about what we can do. So that's why we are talking in context of public-private partnership. Well, taking the previous question also, I think when we are trying to introduce family medicine, we need to recognize family medicine as something important, something prestigious. But this is a cultural thing. I think it will take time to establish. Nobody gives away its stuff. So if specialists are having a field day and all the primary care patients are also coming to them to give a vada doctor, so they are not going to dispense away with their status just like that. It is a turf that has to be competed at. I feel honestly that the primary care physicians actually conceptually are at a much more advantageous position. Why? Because herein, let me start with the UK model. Usually what happens that in what they call their surgeries, so if I am registered with a doctor there, my wife is going to go to the same, and we'll try that our children also get registered, and if my father is coming in, ultimately what happens is their sway over, winning hearts and minds of not just the individual and family holds strong. And then it's a matter of time that, I remember when I was working in the UK system, the practice was we would dispense a cardiology consultation and we would have post-consultation. The transcriber would print out 3 letters. One will go to the patient, one will go into the record, and the third one would go to the GP. And so many patients, my patients and outpatients would say, do I need to come back to you? And so many would say, okay, fine, I'm done with you. And why don't you discuss with my doctor? So in the psyche, that is a psyche that has established itself in the UK system over decades. And that is why in the National Health Service in UK, I think there is no dispute. I'll give you one example because the financial aspect will come in. In 1990, I was living in this southern district of London, Croydon, which was a relatively modern London. And you know, on these weekends, they throw this, all that advertisement, your local newspaper hota hai, which has hardly any news and all advertisements. There was one news item which was very interesting. So somebody had run this article that what is the annual take-home salary, what are the emoluments of doctors of Croydon. Now that was very revealing to me because I quickly looked at, being a cardiologist, where do cardiologists figure in? So that was a very neat intake. It was 114,000 pounds sterling per year. I think amongst specialist doctors, it was either neurosurgeons or orthopedic surgeons, which was on average earning 144 or 148,000 pounds. But you know what was the average salary of GPs of Croydon region? I still remember when it was 191,000 pounds. Now that is the status that they had acquired through establishing their credibility, through linkage and performance with the society. They stand much better chance to link up with the society in a much deeper fashion because they are looking at not only the mother, father, sister.
Yeah.
They are actually stronger. We have just not played the game yet.
I think that's, so I'll request the audience that we are towards the end of this session, 5 more minutes. Please, I would require your patience. If you have to talk, please go outside. So we are coming to the end of this session. The next question is that how can we collaborate with the pharma industries without the ethical, obviously, dilemmas and so can the family practice as a discipline or BHU or primary care health centers can collaborate with pharma? Who will take this question?
I will take it.
Sure.
I think pharma should not be allowed access to any physician. They can possibly mail the information. The continuing medical education is an essential part of every single physician's day-to-day working. All of us have to keep ourselves updated on all the latest medications, side effects, drug profiles, etc. And no incentives should be given by the pharma. There's a huge medical ethical question. We cannot be utilizing our patients for the financial benefits of the pharmaceutical industry. I think there is no two ways about it. Thank you.
Thank you, Naim. Yes, so as you can see, I mean, most doctors are very ethical and grounded in ethics, but that's also a Nahid's favorite topic, and she has lectured widely on medical ethics. So I think we have few questions that we can answer later, and we'll get to that, but I would wrap it up this session by this last question. And it says to the panelists that because there's a lot of shortage of family practitioner, family medicine, can those foreign medical graduates, I think they are referring to coming from China and others, have to, do these NBME exams. Can they not be incorporated in the system as such that we should train them for a year or two more and get them to work in the rural setup?
Well, on the face of it, it sounds a reasonable thing to do, but you cannot have a regulation and have a sub-regulation which doesn't, which bypasses it. If there is a regulation that anybody who's trained at a place which is not recognized by PMDC or higher HEC and they have to go through it, you cannot bypass that. So two wrongs don't make it a right, whatever the needs be. But we have so many of Pakistani origin trained in Pakistan doctors. Why don't we use them for all of this?
Right, I agree that we cannot dilute the standard of the family. We are already saying that the family practice is the most important discipline in the healthcare. So we really would like to be on a very high standard and not dilute any training or shortening or bypassing the regulations. So by that I would...
Can I add one comment about the last question about trying to stop the patients coming from the tertiary care? In a universal health coverage, there is now discussion in an area not far from here, and I have not disclosed exactly where we are discussing trying to link a public sector tertiary care hospital along ring-fenced primary care services in that region, which would then drain only into this place. And they will be all connected electronically as well as in many other collaborative ways, so that at least a model of one region can be built where we can see what is the demographic problems, how you can deal with primary care, referring to the secondary care and tertiary care and then back. So it has to be two-way traffic. And then hopefully if that model works, this may be able to replicate in other parts of the country.
Right, thank you very much. So a big round of applause for our chair, the speaker and the panelists. It has been a really wonderful session. Thank you all.